So if we're considering long lever approaches to the lumbar column and we look at what we've already shown in lateral, we can compare that to supine. Now, the challenge with supine is that the vast majority, or 50% of the patient technically, is essentially stuck to the table. So the table makes stable, which means that if I'm going to try to generate movement, I'm going to have a harder time. So I can do long lever traction. I'm going to try to be careful that I don't obscure everything. So if I'm trying to essentially open the left side, it is the left side. Yes, the left side. When I'm trying to do that, I can explore where the leg will bind up a little bit. So here I get some traction. So I've got a little bit of external rotation. In this case, when I internally rotate and come slightly closer to midline, that's better traction. Yeah, so agreement to better traction. So you have to explore the position of the leg in relation to the body that will allow for some better connection or better bind. You actually want to create some bind in the leg. The leg should feel like it starts to tighten up, but not get so tight that the person wants to protect themselves. And then you can just lean back. Now, if you pay attention, you'll actually see the head move, right? Or if you look at other areas on the body, you'll actually see that move. Now, the problem with that is that it's actually hard to localize into the lumbar column because I'm just dragging the whole body. So it may not feel very specific, and I don't have a good ability to pay attention. Now, if I do this, you feel that something in your hip. I'm not adding any traction at the moment. If I traction there, you feel that kind of right at the base of your vertebral column.
Yeah, I would say like almost like right at the bottom of my lumbar and sacrum.
Yeah, so kind of lumbosacral. And the way I tell is I look. If any movement happens beyond where I'm looking, I've gone too far. And a tiny bit of lumbar traction you feel?
Yeah, now it's more in the lumbar.
Yeah, a tiny bit. But it's not great.
No.
Yeah, so agreement, not great. The lateral methods worked better?
Yeah.
Okay, sweet. Lateral methods work better. So you can do it in supine, but because the patient is connected to the table and you can only get inferred senses of bind and visual representation of where the movement is going, you have to be really smooth and really slow, and it's not as good. So lateral is better if you're trying to use a long lever method to generate opening of one side of the lumbar column, aka opening a side bend.